Shemy Carasso. Dr. Carasso is the director of the non-invasive cardiology at the Korea Medical Center. He's a skilled echocardiographer, especially interested in deformation studies of the heart.
Okay, I'll try to speak about how do we measure function in our patients, in our oncology patients, and I'll show a little bit of our experience and others' experience. Well, the most preferred parameter that has always been used is the ejection fraction, which is measured by various methodologies. The first one is the visual score, and you can see that there's a 5 to 10% increments, so that it's a very difficult parameter to follow and to see minor or minute changes. And the other thing is about the visual score is it's something that is very much needed with a lot of training. The other thing that we do the T-Schultz. It is automatically done in all the echo machines. It only looks on circumferential function, only one aspect of function. So we assume that the others all the other parameters are similar to that, and that there's no other or wall motion abnormalities in other aspects that are not seen in that picture, which is the one on the left. The other thing, the most commonly used and most endorsed by the American Society of Echo and others is to use what we call the biplane Simpson's rule, and it's a way that looks at the end diastole and systole, doing endocardial contours and measuring the difference, calculating for that by a very elaborate way of measuring volumes of discs, and usually it's quite representable. But the best way probably to do that is to do it on 3D echocardiography. We have the best correlations with MRIs. It most of the time is semi-automatic because the contours are produced by the systems by themselves. And if we look at the 3D left ventricular EF with the correlation coefficients and the blunt Altman curves, we can see that it correlates very nicely. So this is one method. What are the caveats of LV ejection fraction? First, it is obtained by echographer. It has a 95% confidence interval and a very large standard deviation. So subtle changes, as I said before, are very easily missed. It depends, of course, on image quality. It is a little bit load dependent and a little bit heart rate dependent, so it's very difficult to follow that way. The next thing is something that is around commercially since 2005 is what we call mechanical imaging, myocardial mechanics imaging, and the concept is strain. Strain comes from physics. It takes measure deformation in one axis. We can do that, of course, in many axes. But what we want to have is we have an unstressed length of a material, and then we either lengthen it or shorten it and measure the change by percentage. If we look at what we have in the left ventricle, the normal number is of shortening is about 20% shortening in systole. This is probably the normal number, and in circumferential we have a little bit more, and we have a gradient from base to apex, which increases. The larger negative number, of course, means more shortening and better contraction. So what do we measure? I mean, the machine that does it actually follows speckles of light, and then we can measure displacement. We can measure displacement in the radial direction, which is in what we look as thickening. We can do it circumferential displacement, which is the rotation, which changes from base to apex, both in magnitude and direction. And we can look at longitudinal displacement. If we take two speckles that are adjacent and measure the distance between them, we can actually measure the strain. And of course, the same parameters, circumferential, longitudinal, and we can actually measure a geometric average of them, which is called the principal strain, or the strain vector, in the direction of the actual shortening of the sarcomere. We can measure thickening, which is the radial strain, and we can measure the time derivative of that, which is the strain rate. So this is how it looks. We will get a graph that starts from 0, which is the unstressed and diastolic length, and then it shortens by 20% and goes back to normal, to baseline. One measure that is has become the most stated by all the studies is what we call the global longitudinal strain, which is the average of longitudinal strain at time of aortic valve closure. We measure the strain, the peak of strain, or the number that crosses at the timing of AV closure, and we get actually a peak that is meaningful about what happens, what is contributing to systole in these patients. Another thing that we can measure is, if we look at that, we can see that not all the peaks happen at the same time, so we can actually measure the peaks themselves, and then I'll go back to that because this is another way to look at what happens in oncology. So if we look at studies about strain and LVEF, and we can measure, and if we look at the left side graphs, we can see that the changes in strain are earlier than changes in EF. We can see that the higher part here shows that we have nearly the same EF, but already significant decrease in longitudinal strain, which is of course what we call the global longitudinal strain. And if we look at all kinds of parameters that have been looked at, and we get the best ROC curve for the GLS, or global longitudinal strain. So if we look at the position paper, and the position paper that actually, not the position, but of course there's a summary paper of a lot of work that has been done using strain. It was done by Palandish Savarnathan from Toronto. And if we can look at all the largest table in the manuscript, you can see that any parameter that is derived from this software has been tracked. Global longitudinal strain, rotation of the apex, difference between rotation of the base and the apex, what we call twist. We look at strain rate. All these parameters have been checked, have been looked at, and probably the best one that has remained, the one that is the most robust, is the global longitudinal strain. And if we can see actually that the changes in the prediction of reduction of EF, what we can see that the global longitudinal strain is actually the one that is the most predictive. So what are the conclusions? In 1,504 patients during and after cancer chemotherapy with done 3 clinical relevant scenarios. Speckle tracking was done. Peak systolic global longitudinal strain was measured and appeared to be the best measure. There was a 10 to 15% early reduction in GLS by speckle tracking during therapy, and it was the most useful parameters. And GLS correlated with prognosis and reduction in EF and heart failure. So what has been one of the most approaches of that system was its reproducibility. So if we look at EF by 2 dimensions, we get, if we look at the inter-class coefficients, we see the lowest number for 2D, a larger number, a better match with 3D, and the best one, of course, comes with GLS. The other thing that is important about strain is the experience of the user. So this is how the inter-observability changes, or inter-observability changes with the experience of the observer, the one who does it. If we look at the one that has done no cases, we have a very large variability, but the one who has done more than 100 and sometimes even expert more than 10,000 cases before, we see that we have a large reproducibility of the results, and we can actually count on it. The most important message of this slide, which is very important, is that you have to do strain a lot to be reproducible, meaning that you have a learning curve that you have to fulfill and work until you can say that you can reproduce your results. In 2016, we had a position paper of the European Society of Cardiology about the follow-up of patients of cardiovascular toxicity. And what we can see here is above the LVEF, that is everybody has been speaking about all the time, we also added the global longitudinal strain as a part of the system we evaluate. The one thing that is important is that they ask us actually to see if there's a change in all these parameters, meaning that we need to have a baseline first. So this is one thing that we have to bear in mind, that in patients we are going to treat with cardiotoxic drug, we should have a baseline echo to know how it decreased later. And if we want to look a little bit further into even more interesting parameters of strain, of looking how things change with treatment, this is actually not one of the drugs that we've talked about. This is a patient treated for Crohn's disease with infliximab, which is also biologic therapy. And we can actually see in that first panel that we see that we see all the peaks joined together. I mean, if we look at what happened in the aortic valve closure and together, the all peaks coincide. So if I calculate the global longitudinal strain and the average of strain peaks, we get a number of 1. Then I'll show that later. The first stage, however, is you get a normal average strain, but you have a large dispersion of strain. You have areas with compensation, and you have areas with low strain. So the average strain will be normal, EF will be probably normal, but you already see that there's some changes. When you get abnormal strain, which is the average is still, you have a large dispersion of strain, but still now the average is below normal, then you will have probably reduced EF. This is the other term that we're looking for, and if we go back to the lecture that Oren Kaspi gave in the morning, we know that there's conduction abnormalities, we know that the QRS is prolonged, so we're looking also for something that is electrophysiology, I mean, looking for delays. So one way to see about the synchronicity of the contraction of the left ventricle is to look at how the peaks coincide. If they coincide, you will get 1 as a fraction of the average strain versus the average of peaks. If you have peaks that happen before end systole and after end systole, you can actually get an average graph that is lower than the average of the peaks. So you can actually create a global mechanical synchrony index, and if it's less than 1, or a lot less than 1, it could be a very early change that you can actually look for. And this is how it looks for 17 segments. You can actually calculate it. It's in normal patient, it's near 1, and it's very uniformly so. And in patients, this is an example for patients with hypertrophic cardiomyopathy. You can actually see that you have a larger dispersion of timing of strain. So if you have a very minute desynchrony that was not there to begin with, you can actually see or anticipate reduction of strain. Another way to do that is, of course, in 3D. Now, various machines have the ability to do 3D strain. They can do it actually by taking a 3D image and then, I would say, downgrading to the regular 3-chamber, 2-chamber, 4-chamber views and do the strain from all of these, or actually calculate the actual principal strain in direction of contraction, like we've seen here. So we get a 3D strain map. Actually, will give you the number for the actual strain that looks at the longitudinal and circumferential strain at the same time and gives you actually an understanding of its compensatory state. So this is all we can say about strain. The most important message is if you want to see changes in strain, you have to have a baseline. The second message is if you want to do strain, you have to do it. You have to do it in your regular cases, you have to do it repeatedly, and then when you have your first oncology patient, you can actually do the follow-up. What I do in my lab is, because there are differences between the methodology between machines, and people come all the time, and they sometimes encounter a specific machine from a specific vendor anytime they come. So what I say to my staff is, when the patient comes and he's done on one vendor's machine, he's now married to that machine, and the next time he has to be checked on the same machine, so that I don't have an intra-machine or inter-vendor viability on top of my own intra-observer viability. Thank you very much.
Thank you very much, Shemy. Excellent talk. Questions from the audience?
Yes.